A little bit about my background. I have been with public health for 25 years. I guess you could say I'm a career public health servant because I came out of college and worked retail for a while. And then, because my degree that I got from Montevallo was actually in business administration, so I thought, how cool would it be to manage a retail store? Yeah, not cool at all. That was the least fun I ever had. And then I got a real lucky break. I had worked while I was in college for the state and worked every break, every summer, every Christmas. And it was through that work that I was actually recommended to be hired full-time. And I don't know how much you know about the state process. It is a laborious process to get hired. It's filling out applications, doing questionnaires, and then just hanging out and waiting until somebody has a job opening. So I did retail, then I came to public health. I was in public health, you serve a 6-month probationary period. I was in 5.5 months and I got laid off because of a funding crisis. So I went to work for a bank, came back to public health, thankfully, 6 months later, after having asked the question, am I going to get laid off again? Because, you know, that was no fun whatsoever, because at that point, I was like you guys, I was in a master's program. My parents were moving 400 miles away, so all of a sudden I was no job, no home, no parents. Okay, that's a kind of scary place to be when you're 22. So I came back to public health while I was getting my master's degree. My master's degree is in human resource management because I thought it'd be really cool to work in human resources at the time. No, there is nothing fun about dealing with personnel problems. Which I do on a daily basis sometimes. As Lisa mentioned to you guys, I've worked around the South Central Public Health Partnership for many years. I went through the Leadership Institute, which was a year-long program, and I went through the National Public Health Leadership Institute, which was also a year-long. Two really fantastic opportunities that I got to meet a lot of neat people and learn a lot about myself and a lot about public health. I'm also a commissioned officer in the U.S. Department of Health and Human Services for the FDA. Well, that sounds really impressive, doesn't it? Well, let me tell you, all it means is I can go out and do FDA inspections, which I'll talk a little bit about in the rest of my presentation. And it also means that I have access to non-public information. So if they send out any alerts or any bulletins. So it sounds really cool. It just means I have access to non-public information. So talk to you a little bit about my professional career at public health. I started off in the WIC program. How many of you know anything about the WIC program? Awesome. Okay, I spent my first 10.5 years working in the WIC program. I started off working in their data management section, which really was responsible for a lot of stuff I won't bore you with, but it basically dealt with the checks and accounting for the food instruments that we gave people. From there, I became the clinic administrator. We have a WIC-only clinic in Montgomery that serves as a training facility for WIC staff. So I became the administrator of that clinic and the training coordinator. They got a 2-for-1 because you had to do both. So all that meant was I had to handle every time a ceiling tile fell, and then I got to train all the staff how to properly handle WIC. So I did that for a long time. Then my then state health officer at the time asked me if I would become the acting director for the Center for Emergency Preparedness. We'd had some staff changes, and he asked if I would do that and help identify a permanent director, which I said, well, let me think about it. And my boss said, well, yeah, there is no thinking. You're going to do this. So I said, fine. For how long? They said 3 to 6 months. 18 months later, I was still there, which was fine because it actually was one of the best things I ever did. So I say that because had I not taken on that new challenge, I'm not sure I'd be where I am today. So sometimes the path to where you want to get to is not a straight and narrow one, and sometimes you have to step out of your comfort zone to get where you want to go to. Emergency preparedness was not my thing, but I sure learned an awful lot about it during those 18 months. So then I came back home to where I was officially the training coordinator for the department. So I handled all the workforce development work for the department. And from there I became the deputy director of this Bureau of Professional Support Services, which was kind of an administrative arm of the state health officer's office, if you will. And then I became the director. And from there I became chief of staff. So I've done a lot of different stuff. I've loved every minute of it. I would tell you that there's not a day that goes by that I'm not thankful that I'm in public health, because it is a great place. So what do I do? Well, we like to say I'm kind of my boss's keeper, because I work directly with the acting state health officer. So I spend a lot of time with him. But really, I analyze management and operational issues through the department. I assist in the direction of the agency, do a lot of strategic planning, a lot of strategic thinking, a lot of brainstorming, resolve staff issues or questions, because we are a 3,000 person strong organization, so that doesn't take up much time at all. Analyze and develop response to federal and state legislation, both what's current and what's being proposed. When you work with the legislature, and that's another part of what I do, as a state agency, we're not allowed to have lobbyists, either on contract or paid, but we do have legislative liaisons. That would be me. And so what that means is you're playing offense and defense against legislation. How many of you are familiar with legislative stuff? Okay, it is the most fascinating world to live in. So if we propose legislation, my job is to sell it, not only to the person that agrees to be the sponsor, but to sell it to everybody that needs to vote on it. There's a lot of walking through the State House involved in that. Or if there's a piece of legislation that somebody else proposes that is going to do damage or harm to the department, it's my job to educate the legislators on why that's not a good idea. So as you can imagine, that is a very time-consuming thing to do, so I'm very thankful that hopefully soon we will have a full-time person in place to do that for the entire department. So with your legislature, in my role, we do a lot of negotiating with them. We do a lot of nurturing, because a lot of the political process and a lot of what I do is nurturing and building relationships and building that trust and credibility. And that goes across the board, whether it's with the staff that I work with every day or the legislature. But one of the most interesting things that I learned when coming into this position was not only there was a lot of stuff I had no clue about. I've been in my role now for 6 years and I still don't know everything. And a lot of days I feel like I know a little about a lot. And sometimes you just don't feel like you are doing anything you do justice, because there's so much. But one of the things that I learned when I came into this role was we also have to do a lot of negotiating and nurturing with our stakeholders. Sometimes we get inside our walls and we forget that we need to be touching everybody outside of us. And before we make a policy decision, we need to really get with the people that it may impact and be sure they're on board with it. So that has been just a fascinating part of what we do in public health, because a lot of these people we're negotiating with and nurturing along the way, we actually regulate. So it's just kind of a very interesting balance that we have to do. These are a couple of other things programs that I supervise and I oversee their operations. You can see them there. It's environmental services, health promotion and chronic disease, Office of Program Integrity, that is our internal audit section, and the Bureau of Professional Support Services, which I'll give you a little more detail on each of these in a few minutes. Our Assistant State Health Officer for Regulatory Affairs just retired. So since he has retired, I now oversee the operations for our Emergency Medical Services Program and for our Office of Radiation Control. which I'll tell you about. Did anybody realize that public health has Office of Radiation Control? Yeah, I know we do a lot of different fun stuff, a lot of fun stuff. For about 2 years, give or take a month or so, I also was responsible for the Children's Health Insurance Program, which some of you may have heard of as All Kids. The Bureau of IT, I am a non-technical person, so those were always fun meetings when they had to explain IT stuff to me. I was responsible for the Centralized Billing Unit and the Center for Health Statistics. So because of my experience in seeing and overseeing a lot of these programs, now you kind of may understand why I feel some days like I know a little about a lot. Because a lot of these, with a lot of our programs, there are rules that go in place with them. Some rule sets may be a few pages long, some may be a few hundred pages long. So it's just not possible to know it all, I don't think. Okay, so I'm gonna back up because I don't want you saying that for a second. So, when you hear Department of Public Health, what do y'all think of? Okay, that's not rhetorical. Somebody holler out at me. What do you think of when you hear Department of Public Health?
Newborn screening.
Newborn screening. Yes, we do that. Vaccinations, yes, we do that.
Pollution, sewage.
Sewage, yes. Outbreak investigations. Y'all are good. Yeah, those are all core public health functions. And yes, we do that, and we do a lot more other stuff. But you can see here what we're responsible for. Providing public health services for improvement and protection through disease prevention, assurance of services to resident and transient populations regardless of their ability to pay. So a lot of people think public health, they think clinic, they think county health departments. They don't necessarily think of or realize we have the breadth and the depth that we do in terms of programs. So, what is our structure? We are, unlike many state agencies are cabinet agencies, and by that I mean their commissioner is appointed by the governor. And where that becomes important is in terms of strategic planning for a state agency. Because if you're in an agency whose commissioner is appointed by the governor, you stand to get a new one every 4 to 8 years. We're very fortunate. We're treated like a cabinet level agency, but we're not. We are actually overseen by the State Board of Health, which is charged with the responsibility of safeguarding the public health through enforcement of public health laws. There are a ton of public health laws on the books, about 870 some odd pages worth. There's so many of them that we no longer print them out. We're given an icon to stick on our desktop because it's just too much paper. So the State Board of Health actually meets once a year, but they function through the State Committee of Public Health. And I'll show all this to you on an org chart in a minute. The State Committee of Public Health is 12 members of the Medical Association of the State of Alabama and the chair of each of our 4 councils that we have that are in statute. So there's 16 people on the State Committee of Public Health. The committee elects the state health officer, who is allowed to handle the day-to-day operations in their absence. So, State Board of Health, State Committee, State Health Officer. That's kind of how we are structured in terms of our governance. Now, we have a central office, which is located in Montgomery. It's in the RSA Tower. It's that big, tall building. And that is divided into bureaus, offices, divisions, units. We have all kind of names. And it just depends on where you are in the box, but you'll see that in a moment. We also have recently as October the 1st, have gone from having 11 public health areas to having 8 public health districts. Now, why did we do that? I'll talk to you a little bit about that when I show you the map. It's about positioning ourselves in uncertain economic times on how we can kind of be leaner and meaner and better utilize our resources that we do have. We have county health departments in 66 counties of the state. Yes, Alabama does have 67 counties, but we closed one of our county health departments, which we hoped we would never have to do, but we did. So we're now in 66 counties of the state. As I mentioned earlier, we do have 3,000 employees, and that's at all levels. That's central office, district, and those employees in the county health departments. So this is our org chart. It hasn't always looked this way, but we went through in probably 2015, somewhere 2014, 2015, somewhere around in there, a span of control study. Every now and then you get tapped to do a study or to let someone do a study on your agency. This was a study that the legislature commissioned wanting to look at span of control. And they looked across a large agency, a medium agency, and a small agency. And then they took into consideration the diverse functions of the agency. And then they looked at an agency who may be relatively large, but they all kind of did the same thing, like corrections. You know, what you do in one prison, you're typically going to do in another. It's not quite as diverse as us. So through that span of control, at that time, the state health officer had, I think, around 21 direct reports, which is way too much for a state health officer to have. So we reorganized the central office, and we came to look like this. So you can see that the direct reports now are actually only 6 to the state health officer. And it's our public health administrative officer, and you can see underneath Kathy are all the bureaus that she's now responsible for. And that's the child health insurance, our facilities management and technical services. I'll talk to you about them too. They're not only responsible for our buildings, but we have a technical services unit that reviews plans and inspects healthcare facilities. Our finance, our health statistics, IT, billing. Then we have a chief medical officer, our general counsel, who now houses our compliance. What is compliance, you say? HIPAA, mainly. They look at HIPAA, they look at privacy, security. Then there's myself, our human resources director, who also is responsible for our employee relations, and that is the box in our organization that handles not only employee grievances, but they look at ADA accommodations and those kinds of things. And then our field operations director, he is now responsible for all of the districts and local health departments. So he handles everything that happens out in the field. That's the best way to explain that. Now here's our pretty colorful new district map. And as I mentioned, we did go by public health areas like 1, 2, 3, 4. And then we decided if we were going to districts, let's make them mean a little something to the public, because you constantly had to explain what 1 and 2 meant, you know, and you ended up using your geography going, well, public health 1 is in the Northwest. So we renamed everything. And so we have Northern, Northeastern, West Central. Now Jefferson and Mobile are a little bit different. We are actually, as a Department of Public Health, 65 counties are under our jurisdiction. We have 2 true standalone local health departments, and that is Jefferson County Health Department and Mobile County Health Department. And when I say true local, in our world, a local health department has its own governance. Like they do in Mobile and Jefferson County, they have their own local health officer. They have a separate personnel system, a separate financial system. They truly are standalone. Does it mean they don't work with us? Absolutely not. We work really well together. It just means they can set up slightly different rules than we do, but typically they don't. We pretty much work lockstep with them. So part of what we looked at when we redistrict, and this was it was a 5-year process to look at. Part of it, we were making some pretty good headway and really thinking through what would be the impact if we do this. And again, we had to pay attention to decreased funding, which there's so much uncertainty. I don't know how much you all know about or listen to state politics or anything related to funding. Our state is one of the very few states that has 2 different funding pots to fund your government, and that's the general fund and the education trust fund. The general fund has your big boys in it, like Medicaid and the Alabama Department of Corrections. We have general fund dollars. The Department of Human Resources has general fund dollars. I guess the take home from this is you've got a lot of really big agencies that always need a good bit of the resources, and your general fund is built on slow growth taxes. So that means you don't get a lot of income and increase in what you've got available to divvy out to run your state government. Then you've got your education trust fund, which is exactly what it sounds like, primarily education and some small bit of other things. That's where all your fast growth taxes are. So that's why a couple of years ago they passed what was called a Rolling Reserve Act that capped what they could appropriate to state agencies, and everything else went into, we'll call it a savings account. So that's why you hear so much debate about the general fund, because it really does fund a lot of your larger state agencies that provide services to the most vulnerable of us. To give you kind of a scope of the general fund and where it is compared to where it used to be, we used to, I'd say back in, I'm going to get the year wrong, several years ago, probably 2011 was the last good year we got a large appropriation. We got around $80 million out of the general fund. So that was 6 years ago. Our FY17 was at 32 million. So from 80 to 32. So we recognized that trend is likely to continue because the taxes aren't rolling into the general fund. There really is not a whole lot of appetite politically to raise taxes. I know y'all have seen all the lottery arguments back and forth. That had started to gain a little traction in terms of being able to fund and help the revenue situation in Alabama. Politically, I don't think that will be anything they entertain this year because it's an election year. So their focus is campaigning, and I get that. So we got to thinking over the past several years, what do we need to be thinking about? And this came up because we needed to better position ourselves to utilize our existing staff because we knew we weren't going to be able to staff to what we needed. So we looked at everything we could possibly look at. We looked at interstates, population. If we draw the line here, are we going to bankrupt one district and make one district really flush with cash? How easy geographically is it going to be to get within your district? So there were so many considerations that we had to go through. We had to look at what our clinic business was, just to try to make the best decision possible. Is this perfect? I doubt it. Will we constantly look at it and evaluate it? Absolutely. Could it look different in the future? Sure. So we just had to make the best decision looking at all the factors that we could to better position ourselves for continued lean economic times. Now, I've mentioned we have around $32 million in general fund dollars, roughly $14 million in education trust fund. So that's our state money. We do generate revenue in a lot of our programs, and we're very fortunate in that in a lot of those programs, the legislature has, by statute, allowed us to keep that income back into that program. And what does that mean? It means they don't have to appropriate any money to us to run that program. Health statistics is one of them. Our clinical lab also gets revenue, and they run pretty much mostly off of the revenue that they generate. We're a roughly $650 million organization, so we do a lot of revenue generating, but we get a lot of federal grants as well. And that, in and of itself, also gives you pause because there's so much uncertainty at the federal level. I don't know if y'all know that or not. I'm sure y'all follow Twitter. You just don't know from one day to the next what's going on at the federal level. And that is a cause of great concern because so much of the prevention work that we do is funded through federal grants. And one of the ones is the Public Health Prevention Fund. And where it is right now is slated to be on the chopping block. That was one of the things that has been put forth to reauthorize CHIP, which I'll get into in a moment. It's let's fund some of that with the Public Health Prevention Fund. Well, I'm kind of caught in a balancing act because I really need the Public Health Prevention Fund to stay in place, and I really need CHIP to be authorized because either one of them stands to affect a lot of people. So add the federal uncertainty on top of it, and even more reason to be able to utilize our resources. We used to have county level employees. Effective October 1, we don't have that anymore. We have everybody is a district level that works in our individual counties. And that means nothing to y'all, but to us it means the world because the way our personnel system is set up, if this employee was based in Montgomery County, I could not ask her to work 3 days a week in Elmore County because she was strictly a Montgomery County employee. What this does now is all those counties, I'll pick on Southeastern, all those blue counties down at the bottom, I can now move those employees anywhere I need to move them. So if one clinic is slower than another one, I can move them over into a busy clinic. So it gives us as an agency a lot more flexibility. Also, it means if you're overstaffed in one and understaffed in another, then we'll make a business decision to shift staff as needed. So it was really a good thing for us. What's the difference in our roles? Central office is really technical support, guidance. We're the policy setters, the policy makers. The county health departments actually are what I like to call boots on the ground. They're the ones that are providing those clinical services. They're our environmentalists that are going out and inspecting the restaurants. We have home and community services, which delivers care to people in their home. And then our county health departments also offer certified birth, death, marriage, and divorce certificates. And we charge for that. Just a tad bit of history. Years ago, you couldn't get those in each individual county health department. They came straight from the office in Montgomery. So through some automation now, folks can go to any county health department, and as long as you were born in Alabama, you can get a birth certificate. So that was a good thing. All right, now some details. CHIP, Child Health Insurance Program, fondly known as All Kids. It provides comprehensive health coverage to eligible children. CHIP takes over kind of where Medicaid leaves off. So our federal poverty level in CHIP, we will serve kids up to 312% of the federal poverty level. That's roughly $70,000 for an annual income for a family of 4. So it's much higher than Medicaid. We also are different than Medicaid. We're even viewed differently than Medicaid. Not real sure why, because we're very similar in that we're insurance programs, but our All Kids program is administered through Blue Cross Blue Shield. And we use the Blue Cross Blue Shield provider network. So roughly, there are around 160,000 enrollees through the Child Health Insurance Program. I'm proud to say Alabama was the first state in the nation that had their plan approved to start this program back in 1997. And our uninsured rate for children went from a little over 20% to around 2%. So that's huge. That becomes a real big deal because CHIP was only authorized, CHIP is only authorized through 2019 through statute. It was only funded through September 30th of this year. So what does that mean? Well, currently it means our CHIP program's not being funded. Now, why is that a problem? Because it's 100% federally funded. So until Congress can get back to the table and act on some piece of legislation, we're operating on any unspent dollars we currently have. That stands to run out February or March. What does that mean? It means at that point we have to start taking actions to shut down the program until those 160,000 enrollees. So we are hopeful that Congress needs to act. The governor has sent a letter saying, please, please, please extend funding for CHIP. But right now, there are two different versions out there in Congress, one in the House, one in the Senate, and they just can't agree on what they're going to do. The last we heard, they're going to fund it at the 100% for the next 2 years, at which point they'll start pulling back and states will have to start paying their share again, which historically for CHIP is states paid about 22% of this program. So roughly $47 million has been what we needed from the legislature to run our CHIP program. Of those 160,000 kids, 83 of them are actually Medicaid kids. CHIP just pays for them. And I could bore you with the details of that, but that was done through legislation as well. And that actually has helped Medicaid because Medicaid has a higher state match rate than we do. So it would have cost the state more money had CHIP not made this move to pay for those Medicaid kids. And if any time, I'm good with y'all stopping me at any time to ask questions if you want to, okay? So please don't, I'm really informal that way. Our clinical lab, we have 2 clinical labs. Our main one's in Montgomery, and we have one in Mobile. And the one in Mobile only does, I say only, they do STD testing, they also do beach water sampling, and they do shellfish testing as well. And then the one in Montgomery is what I'll call full function. They do everything. The myco, they do the clinical, the chemistry, they do all of that stuff. And they, on average, I think they ran about right under 2 million specimens last year. So they are pretty busy. And then if an outbreak happens, there's only a set amount of time for some of these that they have to run these tests. So that's when a lot of our lab workers are there late at night or on weekends because a lot of our testing is time sensitive. So they're a good group. Then we have our communicable disease programs. These are also in statute. Those are, that is a core public health function. Those programs include STD, HIV, TB, immunization. We used to call it epidemiology, but now we call that division infectious disease and outbreaks. And our IDNO folks last year in 2016 conducted right under about 3,600 investigations. So they are a busy group. And they do interesting ones too, that when I came to work in public health, I never thought I'd ever sit in a meeting to discuss it. Outbreaks of gastrointestinal illnesses at water parks. There was a big one that took place a couple of years ago over in the Auburn area. We also do investigations for foodborne outbreaks. There was one at a wedding not too long ago. We've had to do outbreaks from funeral food. And it's, you know, just all sweet people that just stuck the chicken on top of the air conditioner to thaw it out. And then may have put some in a sink, and they just didn't know. They were just trying to do a good thing, and lots of people got sick. If we determine through these events that caterers that their food was the cause of a foodborne outbreak, we do announce it to the public. So we will put out a news release saying who the caterer was and what happened. So those are a couple of interesting ones. In terms of our TB, we did a large scale, we had a very large scale outbreak back in 2015, maybe 2016. I can't remember the years because they all seem to go by faster. But it was over in Perry County. And that was a very troubling investigation for several reasons, and it was probably one of our more frustrating ones also, because we were in a very small community that historically you didn't find any TB, and all of a sudden we had a ton of cases that we were tracking down. I'm trying to see if I put the numbers down on here. No. But we had hundreds of cases, and then we had several with active TB, some with latent TB, all of whom really didn't want us coming asking them any questions because they had a complete distrust of government and anybody associated with it. And then they didn't really want to tell their business and give us any contact information because they didn't want anybody knowing. So it was probably one of the more time-intensive. We pulled staff from all over the state and deployed them to Perry County for 30 days because we had to really take an all-hands-on-deck approach, because it's no joke if you have people in a small community with active TB. Active TB is no joke anyway, but in a very small community, it could be devastating. High schools were canceling ball games because they were just so worried about everything. We tried to do all the education we could with all the superintendents. At the end of it, what we really ended up having to do was do some targeted incentives. We actually got permission to pay people to come in to get tested. And if you came in to get tested, we would pay you. If you came back to get your results, we would pay you. If you came back to get medicine, we would pay you. And if you finished it, we would pay you. And that seemed to work. We're still seeing some pop-ups here and there, but that was truly one of the biggest efforts that I can think of in terms of in my time at public health anyway. Our emergency medical services, there are licensing and regulatory and office for EMTs. And we license all EMTs in the state at all levels. We inspect all your ambulances. We also inspect the air ambulances. So we have maybe 16 people that work in their office, and they're on the road inspecting ambulances and making sure that folks are getting trained appropriately. They're currently working with their partners to get naloxone out into communities for the opioid epidemic. We've just gotten a nice grant to be able to do that. We have roughly 312 ambulance services through the state, around 1,000 vehicles, and about a little over 12,000 licensed EMS personnel. And that's a combination of all the levels, including the paramedics. So they're a busy group. Then our Center for Emergency Preparedness, they are the primary responsibility, they have the primary responsibility of coordinating and planning our response and preparedness activities. And that may be man-made, because we get a few of those. Not man-made, natural. We don't get a lot of man-made ones, thankfully. Natural disasters. And they also work mass fatalities. They plan for those type of events. They plan for serious infectious disease outbreaks, whether that would be like your Ebola or your Zika. They are involved in those. They also, because our primary responsibility in public health is to provide the primary response for emergency support function 8 is what they call it at the federal level. That's health and medical. So we are responsible for mortuary services and those kinds of things should they be needed. Thankfully, we've only deployed, we do have I'll call it a morgue trailer. We've only had to deploy that a couple of times since preparedness has started. So we're very thankful for that. But that does require not just a lot of cross-agency planning, it requires a lot of exercising and a lot of training. And I know over the years, the School of Public Health has been actively involved with us in those exercises. Okay. Environmental services. This is another program. This is where we get most of our calls from elected officials. And that's because it directly affects their local economies. We inspect food establishments. Those are your restaurants. We also have the authority to shut them down by emergency order, which we do every month. And we shut them down for, we call them routine things. They're probably not very routine to the public, but to us, it's just what we do. For sewage backing up in the restaurant, for no hot water. Those are probably our primary. We have had emergency closures for roof leaking over the cooktop, bird's nest in the cooking area. So we have had those interesting little things. I know, right? This is what I thought. But we do close down hotels. We inspect hotels, and we will shut those down on an emergency basis. Primarily, we do that because of bed bugs. So they have to close and then close the rooms next to them until we have to go in and re-inspect to be sure they're good to go and ready to reopen. So another interesting thing our environmental program does, I don't know if you realize this or not, but any of you that are body art or piercing fans, we regulate those. So we go into and inspect your body art facilities. We do on-site sewage, seafood production. We will go in and inspect the seafood processing plants because they have a set, all of these do, mandates and requirements that they have to meet. And we also go into homes and inspect them for lead. We have a lead certification program that, interestingly enough, we require people that are renovating older homes to become certified in lead abatement. And that's a program that we run, and we enforce that program as well. And if they're not certified and they're doing that type of reno work, we will fine them and issue them a notice of violation. So to give you an idea of how busy our food service guys are, they inspected right under 50,000, they conducted 50,000 food service inspections last year. We go into restaurants a minimum of 3 times a year. And a lot of people think, wow, that's awesome. We used to go in monthly, but as funding got cut, so did the number of times we could go into these. So we go into them at least 3 times a year, more if we find violations. So that just kind of gives you a scope of what those guys do. Then we have our Family Health Service Program. We also inspect jails too. Our Family Health Program is where our WIC program lands. It's also where our infant mortality Our FEMUR is our fetal infant mortality program is in family health. They are all about protecting the health of women, children, infants, families. Our breast and cervical cancer division is also in that program where we help underserved and uninsured females seek out mammograms. The other thing before I leave this slide, our environmental services program does, which I had no clue about, was cemetery guidance. Yes, we'll give guidance to local governments should they ask us to on development of cemeteries, looking at water tables and that kind of thing. So that was also very interesting. Health promotion and chronic disease. I'll try to speed this up for y'all. How about that? This is our program that has a lot of different areas in it. Everything from our diabetes program, our cardiovascular program, communications and health marketing. This is where all of our social media work happens, is in our communications and health marketing division. And I gotta tell you, these guys are brilliant that do this stuff. And they have got us on Facebook, Twitter, Instagram, all the things that my kids know and love. But they do just a fascinating job on a very small budget with a very small staff, but they are crazy talented. Our risk communication activities are down in that. Our worksite wellness, we do wellness screening for all, we go all over the state and do that. We are SEIB, which is our state employee insurance board, and the education insurance board. Both of those work with us to provide screenings to all of their members. So that's a busy group. We also have a video communications and distant learning. We have a TV studio in our building in Montgomery. And we do satellite broadcast and where we can go all over the nation and do education programs. So that's really cool. Telehealth is our newest initiative that we're doing. These guys that run our video communications are another crazy talented group that decided we could buy these telehealth carts or we could, I don't know, make them ourselves for a fraction of the cost. So they did. They designed telehealth carts, and that is a program that has expanded over the past 2 years. We have a lot of partners that we're working with now. The VA, Medical AIDS Outreach. We've got a physician, a nephrologist here at UAB that we're working with on a pilot program, and that's basically where their patients can come into their local county health department and be seen via video by their doctor. So it's a huge win for the patients because a lot of patients may have transportation problems. So it's just a huge win. So we have a lot of partners now wanting to work with us in this initiative. So I think it's just going to get bigger. Health provider standards. This is our licensing regulatory agency where they license and inspect and certify healthcare providers. We are the regulatory agency that licenses and inspects assisted living facilities, nursing homes, abortion centers, ambulatory surgical centers. There's a whole list of them that we license, and we're required to go in them at a set schedule. Like we go into assisted living homes, we're required to inspect them every 3 years. Nursing homes, we are required to survey them. We have to do it within 15.9 months. I have no idea where the 0.9 came from, but 15.9 months. We are required to inspect abortion centers annually. So as we started looking at decreased funding, we started thinking, what are some unfunded, what are some non-mandated things we do that we would have to cut should we get to a point of having to make decisions on cutting services? Because a lot of what we do is mandated. Inspecting assisted living facilities is not mandated in statute. So when the legislature asked us a couple of years ago what we would cut, we said we would no longer be able to go in and inspect assisted living facilities. Well, that may be where Mama is. And so that did not go over really well. But we had to plan for what would we do if we ever got to that point. The other was that we would no longer inspect abortion centers, which did not go over well because that is an important deal to a lot of stakeholders. So those are the kind of things that aren't mandated activities, but we do because it's in the best interest of the citizens. So the fact that we even had to have that discussion was very heartbreaking for us. But we knew that would resonate as well. And then you've got our health statistics, we are the vital records entity for the state of Alabama. The state registrar sits in public health. We are the ones that issue your certified copies of birth certificates, death certificates, marriage certificates, divorce certificates. Once folks go to the probate office to, let's say, get a marriage certificate, we're the keeper of that final record. The probate office sends it to us. And then we can issue the certified copies, which we do a lot. We issue a lot of them. And certified copies when people can't find their original one. We get a lot of calls in this program as well, just, hey, I need your help. Or I have this constituent that was born in Texas, doesn't know how to get their birth certificate, can you help? So we get a lot of help calls for the Center of Health Statistics. They also publish a lot of data, and they do a lot of studies. Because they do collect all of this data. Every field that's that they fill out when a baby is born, we can get statistics off of that. That's how we look at low birth weight babies. That's how we kind of look and are able to get infant mortality data, is based on information that these guys collect. Death certificates, we also issue those. Years ago, it was a total manual process, and it would take forever for a family to get a death certificate. That can be very traumatic for a family that's trying to settle estates. So those are all filed electronic. About 85% of them now are filed electronically. So as soon as that's put in, all the information's put in our electronic death registry system, we can issue a death certificate. So it sped up the process for families a lot, being able to settle their estates. So that was also a good thing. Home and community services, we go into homes and we provide care to patients. Sometimes it is nursing care, sometimes it is respite care, like bathing, helping them take medicines, that kind of thing. So that is in our home and community services program. We also have radiation control. This is the office that does work with the nuclear power plants. We do nuclear exercises twice a year, and that is their responsibility. They also license and inspect mammography machines, x-ray tubes. So they are going into dentist office, veterinarians' offices, to go in and inspect their x-ray tubes. So that's what that group does. They are physicists by trade. We have our Office of Primary Care and Rural Health. They work a lot externally with our other healthcare partners, like federally qualified health centers. They work with physicians. This is, under this office, they administer a program called the J-1 Visa Waiver Program, which they work with immigration attorneys, and that is for foreign-born doctors to be placed in medically underserved areas. This is the group that works with those folks to make that happen. Priority health concerns. Well, everybody has heard a lot about the opioid epidemic. So the state health officer is on the governor's council on opioid misuse and addiction. They've got like 7 subcommittees that are currently working at different ways they can attack this epidemic. And then they will submit their recommendations to the governor December 31st, and she has promised some type of legislation that will happen. What that is, we don't know yet. So, but there'll be something coming out of it. Obesity is a huge health concern in Alabama. So we have a couple of things that we do. Scale Back Alabama, I don't know if any of y'all have heard that. That's a public-private partnership that we work with other Blue Cross Blue Shield, the Hospital Association, and it's a 10-week weight loss program designed to help people make better choices, get better educated, and get moving, basically. Then we have our Get Moving campaign to increase physical activity. iChoice's wellness program, that's a combination of things. That's an overall total wellness program that not only focuses on physical health, but emotional health, spiritual health. It's kind of a holistic approach. And then we have a healthy vending machine program where we made lots of children happy in putting healthy snacks in vending machines. Yeah, that one took a little work. We had some healthcare facilities came on board, thought it was the greatest thing ever, and then we went to some other private entities, and they were like, what? Yeah, no. So that has been a fun program to see different people and different entities finally buy into it. You know, so still a work in progress. And then addressing the healthcare gap, we all know we have access to care problems. We're a very rural state. So that's where our telehealth program, we hope, will help address some of those gaps. Infant mortality, always a concern for us, because if you look at your infant mortality rates and how we try to sell it when we're talking about it is, what if you start off with a room full of kindergartners, and then by the time they make it to seniors in high school, how many of them are left? So we try to paint a picture in terms of what infant mortality means, that if your rate is, you know, if you lose 500 babies, what does that look like? Because sometimes pictures are the best way to tell your story. Disease control always is working to meet challenges of protecting folks from infectious diseases. That is a busy, busy, busy program. Now, my time is up, so I'm going to run through probably one of the best things that's happened to us in my 25-year career. We are accredited, and this is a national accreditation effort. It's all voluntary, but we were the 26th state, I believe, to get accredited. It was a probably 6-year process. It took a lot of different people making it happen, but it is just so cool to have been a part of that process and see what that means to us as an agency. It does mean that our folks had to buy into and have an ongoing commitment to quality improvement and to changing the overall culture and how we think about things, how we measure things, looking at outcomes. It just totally changed the way a lot of our staff viewed public health. The other thing it did is it took down a lot of the silos that we work in, and folks actually learned a lot about what other people in the agency did. Because in an organization as big as ours, you can get into your program and blind out everything else. So this has been huge for us, and we just got accredited in June, so we're super happy. It helped us document our strengths and weaknesses, transparency, it improved management processes, and it really got a lot of our staff really super excited about quality improvement, which doesn't always, you know, resonate with folks, but it really got a lot of our staff seeing what a difference it could make. So we are super happy. And what we also have been told, a big bonus just from a selfish thing, is hopefully it will help us be more competitive when we're seeking grant money.